Hello, everyone. My name is Eric Glazer, and I help lead physician engagement and social media here at Best Doctors. I want to welcome all of our doctors listening from all over the globe to our latest installment of our webinar series for physicians by physicians. Our session today is entitled Diagnostic Accuracy, a closer look at improving patient outcomes. As usual, we're recording today's session. We should be able to provide access to the on-demand recording by just about this time tomorrow. For those of you who have never heard of Best Doctors, I just want to clarify quickly what we do. We were founded back in 1989 by two Harvard Medical School professors, and they founded the organization with the purpose of supporting physicians in identifying the right diagnosis and the right treatment for their patients. So in other words, we provide detailed expert medical advice. And I am privileged to be joined today by my colleague, Darren Reynolds, who's the Director of Operations down in Best Doctors Australia, and he's going to explain in a little bit more detail a bit about Best Doctors' global footprint. Darren?
Thank you, Eric. Best Doctors is a truly global operation with a presence in 30 countries and servicing over 30 million members around the globe. We have over 400 staff working for us in global offices including Toronto, Montreal, Ecuador, Madrid, Lisbon, Dublin, London, Tokyo, Auckland and Melbourne down here in Australia. Our global network of peer-nominated experts, polled in the US, Europe, Japan and Australasia, allows us to help tens of thousands of patients and their treating doctors to get access to world-leading medical information at a time they need it the most. Importantly, at Best Doctors, we focus on a highly collaborative approach with local medical communities. As an example, here within Australia and New Zealand, we've liaised with the medical organisations such as the Royal Australasian College of Surgeons, the Royal Australian College of General Practitioners, APRA, the Medical Council of New Zealand, the AMA, and the New Zealand Medical Association.
Yeah, and in fact, the reason we invest so heavily in our peer polling throughout the United States and the rest of the world is to fuel our overall collaborative approach to diagnosis and treatment advice. And Darren mentioned we identify our leading physicians by specialty, and these experts are part of our collaborative medical process, and we provide medical consultations throughout the world to our patients, and we actually refer to our patients as members. Our members are actually employees of large global Fortune 1000 companies, and they have access to our medical expertise as a benefit of their employment. So the big companies like Pepsi and Procter & Gamble, well, they pay the bills here, but their employees, they get to access our expert medical advice. They get to access our Best Doctors as a service for free. We provide our members this detailed medical advice through a process that we call an interconsultation. I mean, at a very simple level, we'll certainly provide them with referrals to Best Doctors, to a specialist that they're looking for in their geographic area. But we're better known for our interconsultation, which is this collaborative process that involves a Best Doctor expert, like many of you on the phone today, as well as a specially trained internist, and then a team of nurses and clinical coordinators. And I'm just going to explain very briefly how that all works. We do take a full intake from the patient over the phone, and then we collect all of their medical records. We rerun their pathology if necessary. We re-review radiology if necessary, and then we have one of our internists, a practicing physician, synthesize the case by authoring what we call a clinical summary. And this clinical summary is a 4 to 10 page overview of the case. It doesn't answer any questions. It actually only asks questions, key questions around the case. And then we submit this physician-authored summary to our expert specialists. So like I said, like many of you on the phone, and that's what you are given, and then you provide the patient, the member, with an expert assessment of their diagnosis and suggested treatment.
That's right, Eric. And over the past 23 years, we've developed and refined this collaborative process that allows the leading physicians in the world to work cooperatively with each other and our medical team to provide patients with the best possible medical advice. And in doing so, we really aim to restore, I guess, what doctors loved about medicine and reinforce the reasons that everyone originally became a doctor. Our goal is to draw upon the experience of doctors, like people on the phone, to enhance the healthcare system that they're currently working within. I think it was Charles Darwin who said, in the long history of humankind, those who learn to collaborate most effectively have prevailed. And this webinar is just one example of how we try to add value to all of you, our trusted medical partners. So without further ado, let me introduce our terrific panel of physicians that will be talking on the call today. Dr. Matthew Fink is a Best Doctor, currently Professor of Clinical Neurology and Vice Chairman for Clinical Services in the Department of Neurology and Neuroscience at the Weill Cornell Medical College. In addition, he is Chief of the Division of Stroke and Critical Care Neurology at York-Presbyterian Hospital, Weill Cornell Medical Center. Dr. Mimi Kokoska is a Best Doctor and currently Professor and Chief of Otolaryngology, Head and Neck Surgery at Richard Raudebesch VA Medical Center and at the Indiana University School of Medicine. Dr. David E. Newman-Toker is a Best Doctor and Associate Professor of Neurology and Otolaryngology at the Johns Hopkins University School of Medicine, with joint appointments in health services, informatics, emergency medicine, and epidemiology. He's also chairman of the 2012 Conference on Diagnostic Error, being held November 11 to 14 at the Johns Hopkins School of Medicine. And we'll tell you a little bit more about this important conference later during our webinar. And finally, Dr. Martin Tattersall is a Best Doctor and has been Professor of Cancer Medicine at the University of Sydney and a cancer physician at the Royal Prince Albert Hospital in Sydney since 1977.
Hey, thanks, Darren. Kelly, if you don't mind, if you can mute our panelists again. I think Dr. Tattersall's line provides an echo. Thanks, and we'll unmute when he's up. I just want to thank all our panelists for being here today. We really appreciate it. A heads up to our attendees. Couple things. One is throughout today's session, we're going to be able to take questions from all of you, so feel free to pose them as the discussion evolves over the next 60 minutes or so. There's a Q&A module on your right-hand side of your screen, or at least it should be, and you could type in questions there. I'll be monitoring that throughout the session, and we could interject with questions throughout the discussion, and maybe at the end take a few other questions that are remaining so our panelists can answer them for you, and I'll pass those on to our moderator. Also, we'll be asking you sort of towards the last 5-10 minutes of today's session for your feedback. We're providing these webinars, as Darren mentioned, on a monthly basis, and we want you to provide you with relevant information. So we ask you firsthand what you'd like to hear from us. So look for that survey to appear during the last 5 or 10 minutes. We ask you the favor of completing it. It only takes a couple of minutes to complete. Typically, we're very punctual on these things, and we're 60 minutes, literally wire to wire. I'm going to warn everyone we may go 5 or 10 minutes over. We've got a lot to cover. We've got a great panel, a large panel, so we may go a couple of minutes over. The good news is you won't have to listen to me and Darren the entire session. We've actually brought in the perfect moderator to cover diagnostic accuracy, today's topic, Dr. Mark Graber. He is one of the authorities in the area of diagnostic error. He has received funding from the National Patient Safety Foundation and the Agency for Healthcare Research and Quality to investigate diagnostic errors. Dr. Graber convened the Naples Conference on Diagnostic Error back in 2006, and he's also chaired the Diagnostic Error in Medicine Conference that Darren alluded to, both back in 2008, 2009. This year, he actually founded the Society to Improve Diagnosis in Medicine and is also actively involved in working with some leading physicians on the 2012 conference on diagnostic error in medicine. So, Mark, I'm going to hand it over to you and let you drive the rest of the way.
Thanks, Eric. Thanks, Darren. Appreciate the introductions and for getting this all together. This is a wonderful opportunity to talk about diagnosis. And it's so strange. we doctors, that's what we do. Day in and day out, we make diagnoses, but we never get the chance to just sit down and talk about the process itself. So I'm really looking forward to this. And it is very much a process. It's got steps. We start out by gathering information from the history and the physical and diagnostic tests, and all along the way, we marry this up with the knowledge in our heads to arrive at some possibilities. And everybody on this call is probably pretty good at this. We're affiliated with best doctors in some way, and you're already recognized by your peers to be an excellent diagnostician, and that's what I'd like to talk about. What does that mean? How did you get to be an excellent diagnostician? What lessons and tricks can we share with each other to try and get better? And the issue is especially important to us as we try to deal with the problem of diagnostic errors. That's been my main interest over the past decade. There's really nothing harder in terms of the cognitive challenge than what we do in medicine when we try to come up with a diagnosis. And we do it exceptionally well. The problem is that we're not perfect, and we never will be perfect. We're always just playing the odds. We rely too much on our intuition. Sometimes we get tripped up by system-related issues. So these diagnostic errors are out there, and it's important to start talking about them, how they happen, and what we can do to minimize the chances of error going forward. So that's it by way of introduction. We have a wonderful panel, and we have some interesting questions for them. And let's get started. And Mimi, this first one's for you. Tell us about ENT or surgery in general. Do you think diagnostic accuracy has increased over the past decade or two?
Thank you, Eric, Darren, and Mark. So diagnostic accuracy and timeliness of diagnosis in otolaryngology head and neck surgery have improved as a result of non-invasive and minimally invasive techniques and studies in the head and neck, including endoscopies, Dept, CT scans, and office-based ultrasound-guided fine needle aspiration. The guided fine needle aspiration provides more accurate, earlier, and same-day preliminary tissue diagnosis at initial consultation without radiation. We have shown that if a cytopathologist is available to provide an initial reading also on the ultrasound-guided fine needle aspiration specimen, the diagnostic rate is even better. I would like to think that our teaching of resident trainees is improving based on how each of us reflect on our own training. However, there's still variability in how individual specialists interpret symptomatology, use and time diagnostic imaging or tissue biopsy, as well as how they utilize consultations. There is definitely room for improvement. Thank you.
Thanks, Mimi. That's great. Matt, how about neurology? What do you think about diagnostic accuracy in that field?
Well, there has been a real revolution in the ability of neurologists to make accurate diagnoses with the great improvements in neuroimaging. The earlier slide you showed also demonstrated how imaging has become one of the major drivers of costs over the years. But in my own view, it is a great value, and we get tremendous value for what we pay when it comes to imaging, particularly with the advances in MRI technology, both to look at the structural components of the nervous system as well as the vasculature, and it has had a dramatic effect on the ability of neurologists to make accurate diagnoses. When I was in training, and I'm old enough to remember when I was actually in medical school, it was before we even had CT scans. And what we learn with the development of CT scans and then MRIs of the brain, that even diagnostic accuracy using, clinical abilities to diagnose someone with a stroke were at best about a 60% diagnostic accuracy. That means we were missing, 40% of other pathologies because we had no way to really get accurate imaging of the brain or the spinal cord or other parts of the nervous system. So in my field, imaging has had a dramatic effect on our ability to make an accurate diagnosis, and we are still basically a cognitive specialty. We have some procedures that we do, but not too many, and imaging has just revolutionized the field.
Yeah, we're better doctors because we have better tests. Martin, how about in oncology? What do you think about improved accuracy in that field?
Well, like Matt, I remember the days before CT scans, and definitely imaging has played a major role in the changed approach to achieving a diagnosis and using technologies including fine needle aspiration and core biopsy, which were really previously in the hands of the surgeon with open procedures. So I think that I hope that there has been improved diagnostic accuracy, although the evidence for that isn't all that fantastic, I think. On the other hand, I do think that we're certainly much more able to review the evidence, and tumor boards and multidisciplinary review of specimens and so on, I think has probably played an important role in what I hope is an improvement in the accuracy of diagnosis of cancer. Of course, establishing the extent of tumor spread has also been greatly changed by new imaging technologies, and I think one of the more recent ones, which is still not totally available to all, is the use of the PET scan, which has certainly quite significantly changed our accuracy of determining the extent of tumor spread over what was possible before. I think that the number of patients seeking second opinions in cancer has probably increased. Now, the evidence for that is not all that solid, at least in Australia. There may be better data elsewhere. But I do think that patients have played a role in, shall I say, fine-tuning what doctors do to establish a diagnostic, the diagnosis in a patient who may have cancer. The other feature which I think has happened very rapidly is the increasing organ site specialization of oncologists. And so there is a danger, of course, of falling between the experts. But on the other hand, I think tumor specialization has certainly shortened the time interval between diagnosis and introduction of appropriate therapy.
I would agree with everybody's comments. I'd like to pick up on something that Mimi said about our education being better, and I guess it leads me to this question. You know, yeah, sure, the tests are better, and we have better imaging, but are we better thinkers now than doctors were 10, 20 years ago? Is our education trained us to be better thinkers in any way? What do you all think about that?
This is Matt Fink, because there is a flip side to the benefits of imaging. And that flip side is that often if the neurologist goes immediately to imaging to make a diagnosis, that often leads to errors. And so the educational process, I think, needs to remain the way classical neurology has been trained, which is that we as physicians need to be rigorous in our thinking and stay with the classical training of obtain an accurate history, particularly in neurology, do a careful examination, physical neurological examination, before looking at the imaging. Because in an imaging study, an MRI of the brain may show multiple pathologies, and it's easy to make errors that way if you're not rigorous in your thought process. And that goes back to the classical teaching of neurology, which I think we need to stay with when it comes to teaching students and residents how to go about this process.
Great, thanks. Any other comments on that?
This is Amy Kokoska, and I just wanted to add that so the patient presents with a certain symptom, and based on that symptomatology, a physician a provider formulates a differential diagnosis, and then that's refined as modifiers come into play. As a patient provides more information, as a physician elicits other modifying information, and that symptomatology then becomes modified and refined, and the differential as a result gets modified and more specific. And then, of course, adding the imaging studies, one can arrive at even a more specific differential list. And I think that's where we can teach residents. And I found that if we focus on symptomatology and how to develop differentials based on the symptomatology and refine that, the residents in general seem to grasp that well. And unfortunately, the literature, I think our textbooks and literature does not necessarily teach it in that manner. But I think that that's something I've learned over time, that I think that's an effective way of teaching the residents.
Thanks, Mimi. Anybody else? Any other comments?
Mark, this is David. I'd just like to pick up a little bit on the prior comments, particularly
Please, yeah.
Matt's, just to expand on this idea that the over-reliance on test results is sort of weakening our overall clinical skills. And I think we've been talking a lot about specialists and sort of thinking about it through the lens of specialties. And I think it's even more of a problem for generalists. So they're faced with tremendous amounts of information, great complexity of diagnostic problems in an emergency department or in a primary care clinic, and they have now come to rely so heavily on diagnostic test results that blind obedience is almost the rule, so that somebody will come in with a neurologic symptom and they'll get a head CT, and if the head CT is normal, they'll assume it's not a dangerous neurological problem, and the patient will be sent home. So there are a lot of places, I think, where we're over-relying on the great advances that have been made in technology.
Yeah, that's a good point.
Coming in here, I'd just like to agree with the comments about over-reliance on technology and under-appreciation of the value of the history. I think it is incredibly important that the history remains the first point in the diagnostic deliberation, and that it should guide the tests rather than the tests inform always what's wrong with the patient before a history is being taken.
Yeah, thanks, Martin. I'd like to follow up on one of the other comments that you made earlier, that part of the reason that we're better at diagnosis now is because the patients are more engaged. That was interesting to me. Can you give me an example of what you meant by that? And how does it work that patients help us in this process?
Well, I guess looking across the spectrum of my medical career, even when I moved to Australia in the late 70s, a lot of patients diagnosed with cancer were not aware of that diagnosis. And I know even in the US in the late 60s, there was a high proportion of patients who weren't informed. But now cancer is out there, and patients who are diagnosed with cancer are much more active people in the determination of whether they have a cancer and in the decision-making about what should be done about it. So I really do think that the patient's expectations, plus their awareness of cancer, and of course the media attention to cancer and progress, which hopefully is happening, and I think is to some extent, but there's also a significant media hype. So I think the patient is a better informed person to make sure that the doctor is getting the diagnosis right, and absolutely right.
I'd like to just add something to that. I actually think one way that the patients really help to ensure accuracy of diagnosis is by forcing the doctor to answer the difficult questions that the patients and family may ask. And I think that is a relatively recent occurrence where patients and their families really ask very difficult questions. And it's our obligation, responsibility to give them correct answers. And if we don't know the answers, then we have to find out the answers. And that definitely helps in the accuracy of the diagnostic process.
Right, right. Mimi, how about in surgery? Do your patients walk in and say, I know what I have, please confirm it for me?
Oh, don't we wish? Actually, there's job security, I guess, as a result. But no, as a matter of fact, in most cases, patients don't know what they have, and in cases where they may want a second opinion, they sometimes have a idea of the diagnosis, but not necessarily have been fully educated. So in most cases, patients really present with some form of history or some symptomatology, which as a physician, then need to distill and identify the underlying etiology, and then pursue, further workup.
Right. Well, listen, I'd like to finish out this question with just a little follow-up of my own. I'm an internist and a nephrologist, and in my hospital, we can see, for instance, the chest X-rays in our team conference room. And we don't have to run down to radiology anymore. So when a new patient comes in, we're looking at his chest X-ray or the CT of his head, and we all think we're getting pretty good at this. And I'm worried that because we don't go down and discuss it with the radiologist, we're missing out on an educational opportunity, but more importantly, B, probably some important clinical findings. It seems to me these advances in imaging are amazing, but there's a downside too in terms of the way we're using them.
Hey, Mark, this is Eric. I just want to remind everyone that you could post your questions in the Q&A module. We've had a few questions come in. They're actually comments. I thought I'd interject and pose one. It was a comment from one of our attendees, and I'll paraphrase, where he or she says the most important piece is history, and we have limited time. We're rushed to see our patients, so we don't have the time to listen or even think. I'm wondering if we could get the panel to respond to that.
Yeah, it's a good point. The studies have shown that 80 to 90% of diagnosis comes from the history. Has that changed over time?
Well, so the studies that have looked at it have suggested that it's fallen somewhat over time, although not by all that much. The most recent studies I'm aware of are actually from the late 80s and some in the early 90s, and it was still estimated that about 75 or 80% of the history, 80% of the diagnosis was made based on the history. And I think certainly in neurology that's still the case, if not much higher than that. Those were estimates from general internal medicine clinics. I think the other thing to remember with the issue of history taking is that to some extent we've abdicated responsibility for the way we're electronically documenting things. We now cut and paste a lot of things. We have form fields, and there's the narrative is being wound down as the time is being ratcheted out of medicine. And I think at the end of the day, when we look at the panel of diagnostic errors and the causes, deficits in history taking seem to be a huge part of the problem, as Gordy Schiff showed in his recent article about 583 physician-reported errors, where deficits in the history taking or the examination at the bedside were involved in at least a half of all the cases.
Right. Any other comments?
Then could I just agree with Mark that the online imaging issues do remove you from talking to the person who's preparing the images and actually interpreting them, and we become terribly reliant on the written report rather than talking to the individual radiologist and hearing that they think it's this, but they're not sure. And so the certainty, which sometimes we attribute to the imaging technology, is actually not reflected in discussion with the person who's reporting the imaging technology.
I'd like to comment on David's remarks earlier. I agree completely with what he said, that right now I think we are getting into a near crisis because of some of the problems associated with the electronic medical records. The cutting and pasting the histories, not obtaining information ourselves, but simply copying or repeating what other people have said and done, is a real hazard because sometimes the facts and the important information is missing, or incorrect information is simply repeated over and over again in a medical record. So we have to, I think, grapple with that one, and with the shortage of time for everybody, that's going to be a big problem. But I think that's the downside of the electronic medical record systems that are being implemented throughout the world right now.
Well, ain't it the truth? Thank you, Matt. We're suffering with that at our own place for sure. I'd like to move to the next question. David, we're going to tee this one up for you. What tricks do you use to help prevent diagnostic errors? What can you recommend to others that they try?
Well, I think that it's always a tough question. I think some of the things that people have talked about for many years are things like decision support, education, improving education. I think for the most part, many of these interventions are going to be system-level interventions that are hard for people to implement at an individual provider level. I think probably the things that give people the most hope are things like checklists, for instance. So Don Ely's work and you, Mark Graber, have published some work about checklists for particular symptom-oriented diagnostic presentations in the emergency department. And those kinds of things, I think, are things that individuals can do themselves. In your own clinic, you can develop a symptom-oriented checklist of all the key things that are low-frequency items that you can't afford to miss. And those particular kinds of tools are things that every one of us should be developing on our own. You can also improve your feedback process by being a little more systematic about following up on patients who don't come back to your clinic or who don't return visit, or if you're an acute care provider, following up what happens, and that's all getting easier as the electronic medical records become more universal. And I'd say, finally, if you're at the level of kind of an administrator or a clinical director, I think the idea of sort of instituting algorithms or pathways for sort of common problems that are known to be misdiagnosed on a regular basis and making things more evidence-based and more standardized, I think offers some real hope and potential at the individual level to make a difference.
Oh, yeah. Thanks, David. Those are all excellent comments. Can you tell us what algorithms you have in place? What do you use in your own practice or Hoffman's?
Well, so we take a structured approach to evaluating dizzy patients looking for stroke. In the emergency department, for instance, this is where a lot of my research has focused over the last decade. And we've developed pathways for sort of rethinking about how to evaluate dizzy patients, and we apply those in the analysis of clinical presentations to the emergency department. And what we found over time is that sort of traditional paradigms for approaching dizzy diagnosis probably are not the right way to go, but that there are new history and exam-based techniques that actually outperform some of the diagnostic imaging that has come down the pike. We can actually diagnose patients more accurately than MRI scan in terms of identifying strokes in the acute stages in the emergency department.
Okay, and are you talking about algorithms that you use as a neurologist or ones that the emergency room staff use?
I would say both to some extent. I mean, we've worked on disseminating these pathways within the emergency department. They're things that we sort of operate with on a regular basis, and I personally use checklists as well.
Okay. Yeah, I'd like to come back to some of those comments in a little bit, but Martin, let me give you the opportunity. Any tricks that you use that you can recommend to us?
Well, I think that within the diagnostic accuracy, one of the concerns is that with the improved access to tissue using fine needle and other techniques, there's the perspective that the specimen you're getting is actually representative of the site or the lump which you're trying to diagnose. And there is, I think, a bit of an over-reliance sometimes on fine needle aspiration cytology, which of course doesn't give you the anatomical and pathological relationships of tissues. And I think it's important to recognize the real value of a core biopsy or an open biopsy sometimes to get an adequate specimen with which to establish the diagnosis. It's also, of course, very much part of the modern concern about cancer diagnosis, that perhaps the specimens are, tumor specimens are often highly heterogeneous, and if you're using a tiny fraction of that on which to establish a diagnosis, you may on occasion be drawing the wrong conclusions about what the diagnosis really is. But once it's written down in a pathology report that somebody has an invasive cancer, it tends to lead to stopping thinking about the possibility that diagnosis is erroneous. And I would just like to add another perspective, which I find commonly when I'm sort of serving as a second or third or fourth opinion, is the value of pattern recognition. When things don't fit, particularly when it's a senior clinician saying this doesn't fit, what I'm being told and what I'm seeing doesn't fit, it really should prompt you to reevaluate how reliable is the evidence you have taken so far on face value.
And if I could just follow up on that point, I think that's a fabulous point that Martin just made, and maybe the audience members should hear a little bit about sort of metacognition. I think this idea of thinking about thinking is something that has become sort of a popular way to approach diagnostic error and diagnostic error education, to try to train people to recognize that moment where you're potentially falling into a trap. And I think this idea of relying on that intuition that something's wrong, that there's an opportunity, there's a mismatch or a misfit between what you're seeing and what your expectations were, to leverage that as an opportunity to identify whether there's really a misdiagnosis rather than just get stuck or anchored in the prior presumed diagnosis.
Yeah, thanks, David. Sylvia Mahmood has published on this, and she calls it reflective practice. Recommends that we should just pause and think. How did I come up with this diagnosis? Did I gather all the evidence I should have? Did I think of all the possibilities? And she's been able to study this in trainees and has shown that if you give them instructions to pause and think, what else could this be? They actually do a better job in terms of coming up with more appropriate considerations. She hasn't had a chance to study it in real practice where the real test will be, but I think the advice to practice reflectively is going to be one of those pearls we hang on to for a long time. I'd like to follow up with something, David, that you mentioned about using algorithms. And, they're not really new. They go back a long time. The one I remember are the Goldman algorithms for patients who come into your emergency room with chest pain, and should you admit them or not. So Goldman and his colleagues came up with these very simple rules that were based on just a few facts, and your age and whether you had a known history of coronary disease, just a few simple things. And based on those few items of information, came up with a rule. And when they applied this rule, it turned out to be surprisingly good in terms of putting people in the right place. So whether you need to be admitted or whether you could be safely discharged, that decision was made exceptionally well by that algorithm. But if you look at the history of the Goldman algorithm, it's essentially disappeared. The ER doctors think that they can make that decision better than the algorithm can. And yet study after study shows that the rule performs better than individual judgment. So I'd be interested to find out whether the people on the panel think that algorithms have a future, and if so, how do we get doctors to use them?
This is Mimi, and I was going to make a comment that when we collaborate and educate our primary care and emergency room providers in terms of our specialty as to how to manage certain patients and their presentation, really that process is best discussed verbally with the primary care and the emergency room providers in this case, and then reinforced through formal collaborative inter-service agreements, including agreed upon written algorithms which outline how to work up or evaluate specific patient presentations in a streamlined manner. The algorithms provide a written resource that can be referred to repetitively by the frontline provider as needed, because they may not see a certain type of patient present frequently, so maybe kind of a rare presentation, relatively rare, and so they could actually use these written algorithms to reference and even put between the frontline providers as well, because somebody may have not been present during a verbal communication, and so having a written algorithm, I think, is quite helpful.
Thanks, Mimi. Appreciate it. Matt, do you have any comments on algorithms? Do you use them?
Yes, we use them and we teach them for common neurological symptoms and common presentations because we think that the algorithms are a good way to teach people how to appropriately do the evaluations and to avoid a lot of errors. The problem, though, is when a patient doesn't really fit into the pathway of the algorithm, which happens quite often, so that we really find that they're only helpful for certain common problems. So patients that come to the emergency room with headaches or dizziness or suspected stroke or an epileptic seizure, these are the common problems that lend themselves to the use of algorithms. But very often there are more complicated issues that come up and the algorithms don't work. But they do work for the common presenting problems.
Yeah, good point. So it's nice to know that knowledge and judgment still count. That's good. Any other comments on that one?
So this is David. I'll just, you know, the idea of using small amounts of information is still pretty alive and well. For instance, Ian Steele's group in Ottawa is an emergency medicine health services research group, and they've produced the Ottawa ankle rules and any number of other diagnostically oriented clinical decision rules. And I think that conceptually, it's a great idea. We've tried to do the same. We have a 3-item clinical decision rule for a subset of patients who are at high risk for stroke who present with dizziness, acute severe dizziness. But I think just sort of taking up on Matt's point, it's not just that some of the patients fall between the rules in a sort of an obvious way, like they have, they complain of visual blurring, and you don't have a rule for visual blurring, you've got a rule for something else. But even in a more subtle way, that the issue of when to apply the rule and when not to apply it is sort of often the $24,000 question. The studies that have looked at some of these rules and have shown that they're effective and accurate and sometimes better than individual clinician judgment have often defined very clearly sort of a narrowly defined population of patients. And sometimes somebody comes in with dizziness to our emergency department to whom our rule doesn't apply because they're dizzy, but they're not continuously dizzy. And those kinds of ideas are things that then have to be brought to bear, on the basis of clinical judgment, as you suggested, Mark, and a real knowledge of the evidence. And I think that's what makes it tricky.
And there's another problem, and I'll use dizziness as an example. When the emergency room physician calls a neurologist to see a patient and says the chief complaint is dizziness, and when you go to see the patient actually is complaining of loss of balance or ataxia or something else, and even the word which would trigger a particular algorithm is sort of the wrong chief complaint. And that unfortunately happens quite a bit. Even our language is a little fuzzy sometimes, particularly when you're talking about a word like dizziness.
Yeah, those are all good points. Listen, I'd like to move to the next question, and Mimi, we're going to get this one back to you. And it has to do with the impact of medical homes, which is becoming more and more common, at least in the States. So it's a primary care arrangement, and the idea is that every patient in that cohort has a primary care provider that they're supposed to see for all their problems. And the good thing is that primary care person gets to know the patient very well. But to get to a specialist, it has to be by referral from that primary care person. So what do you think about that? Do you think this arrangement has any impact on the accuracy of diagnosis or timeliness?
In an ideal world where primary care providers are experts in evaluating symptoms and triaging to downstream diagnosticians and specialists, this would be an optimal flow process, which would not negatively then impact accuracy and timeliness. However, in my experience, that on occasion, emergency room and primary care providers do not make the correct assessment and plan, which then results in delays in diagnosis. However, we have also seen where educating primary care and the emergency room providers in specialty-specific red flag symptomatology and appropriate triaging does work and does result in reducing diagnostic errors or failures. So there is hope, and I think it really is dependent on the expertise, if you will, and abilities of the primary care or medical home.
Yeah, absolutely. Good points. Matt, any comments from your perspective on primary care and medical homes?
Sure. I like the concept of the medical home, and I would like to see more primary care physicians take a more active role in the overall management of patients. I think neurologists in the United States, as opposed to, for example, UK or continental Europe or maybe Australia, although I don't know in Australia so much, U.S. neurologists are doing a lot of primary care themselves. And I would rather spend a lot of my time teaching our primary care physicians more about neurology so they can be more selective in making referrals. And that's what we're doing right now. We're trying to teach our emergency medicine physicians, our primary care physicians, to be more accurate and selective in their referrals so that we see the appropriate patients. I think there is a risk that there may be some delay in diagnosis, but I think overall, if we educate the primary care physicians to do a better job, I think overall our patients will be better served.
Good point. Yeah, Martin, I wonder if we could impose upon you, what is the Australian perspective on this? Is primary care growing in importance there too?
I wouldn't say it's growing, but it's seen as a very important part of the sort of gatekeeper function because referrals to a specialist are a prerequisite for being seen by a specialist other than going through the emergency department. So there's no patient access directly to a medical specialist unless they've seen previously a GP, a family physician who refers them on. The difference between Australia and the UK is that patient loyalty to their family physician is extremely limited, and so there's a lot of doctor shopping at the GP level, and of course the records don't actually follow the patient. So I don't think we've got the best of both worlds in Australia. We've got some advantages in terms of the gatekeeper role, but we also have a disadvantage in that there is no loyalty to the general practitioner.
Yeah, thanks. It's interesting. I'd like to ask a follow-up question. I saw at, I think it was Target, someplace, there was a nurse practitioner. It was at a department store. And you could go up to the nurse practitioner and see if he or she could have a shot at diagnosing what's wrong with you. And I thought, what a wonderful way to facilitate access, because so often the big problem is the patient delays in going to see a provider. But then, this is not really the best person you want to be making a diagnosis. They really aren't trained specifically to be diagnosticians. Do you think it's a good idea or a bad idea to have physician extenders so widely available?
This is David.
This is Mimi. I have experience working with nurse practitioners in my specialty, as well as, of course, just in general, our surgeon colleagues. And it really depends on that individual physician extender, how capable and experienced they are, because I've seen good and bad, and in the diagnostic process. And so what we have done is we have had primary care and nurse practitioners shadow us in our specialty clinics so that they can see how we go about the history gathering and diagnostic process, as well as see the algorithms that we have kind of live, if you will, how we go about taking patients' history and their symptoms, and then how we modify that based on, is that a progressive, or is it a progressive chronic symptom, or is it acute, and then how we modify our differential and then proceed with getting down to a specific diagnosis from there. And so having them shadow, having these shadowing opportunities, and again, the collaborative exchange, communication, I think is really important in improving the quality that these primary care and other frontline providers provide to our patients.
Thanks, Mimi. Hey, Eric, if you want to jump in here, I got a little message on the side from you.
Yeah, I do. I just wanted, because it's so pertinent to the topic we're covering today, I know, David, you're chairing this upcoming conference in November, and it's obviously going to be a nice extension of the short discussion that's going on today, so I thought maybe I'd give you a chance for a couple of minutes just to tell the group on the call today a little bit about the meeting. And I know, Mark, you're involved too, so feel free to chime in and tell the group a little bit about this session coming up in November.
Sure, that'd be great. You know, Mark is really the originator of this meeting, and I've had the privilege of being able to run the meeting for the last couple of years, and we'll be doing that again this year. It's called the Diagnostic Accuracy in Medicine Conference, and it's going to be held in Baltimore at Johns Hopkins on November 11th through 14th, 2012, and our theme is going to be accountability and answering the question, what can I do? And our keynote speaker is going to be Carolyn Clancy, the director of the Agency for Healthcare Research and Quality. We've had attendees over the years from multiple continents around the world, including Australia, despite the distance, and we look forward to having robust participation again this year. It's going to be a great conference. It's a 3-day conference with some additional sessions on that are CME education type sessions on the first day, as well as a research summit for those who are interested in doing research in this area. So thanks for the opportunity, and I hope that some of the people on the call take up the opportunity. Just search Google Diagnostic Accuracy in Medicine 2012. And it should come up as a Johns Hopkins continuing medical education activity.
Thanks, David. I'd just like to add on that anybody who enjoys talking about clinical reasoning and how to do a better job with that would really enjoy this conference. We've got really the thought leaders in the field who come and give us the opportunity to think about that for a while. And David's put together an absolutely wonderful program this year, and we're all really looking forward to the conference. So absolutely, please try and come if you can.
One other just comment on this end, as the group on the call probably could guess, or they already know, Best Doctors as an organization is just committed to the study of diagnostic error and the improvement in just clinical decision making in general. It's what we're all about. We're doing something for the first time this month, in that we're creating a newsletter, and it's not a traditional newsletter where we're just writing. We're actually going out and aggregating content on the web around diagnostic accuracy, and we're going to give it a shot to see if we could create some valuable content for all of you. We'll frame out the upcoming November conference as well. We haven't done that in the screenshot, but we'll make sure that we do that. And if you want to sort of get a copy of this or a link to it, you could request that through the feedback form I'm going to put up in just a moment. And to that end also, if any of the folks on the call want to at all contribute to this newsletter by participating through an interview or writing a post or helping give us access to any of your studies around diagnostic error and accuracy, we'd be happy to include it in this thing on a monthly basis. So just a quick little plug for a new initiative we're putting together for all of you around diagnostic accuracy and the content. We have time for a couple of more questions, Mark. I'm going to throw it back to you, but meanwhile, I am going to put up the feedback form so we can get some recommendations from everyone on the call about topics that we could cover in the future and how we could continue to provide valuable content to our best doctors. So, Mark, I'll send it back to you.
Okay, thanks, Eric. I think we have time for one last question. David, we're going to direct this one to you. it's an interesting question. You know, diagnosis used to be a private affair between the patient and the physician. It was kind of one-on-one. But now we have the opportunity, thanks to Best Doctors and other venues, to get second opinions. And I guess you could extend the concept to getting multiple opinions on one case. So you could collaborate and benefit from the wisdom of the crowd. What do you think about this approach? Do you think it's going to help us get the diagnosis correct, or is it just too many moving parts and more opportunities to lose information with all the handoffs that would be involved?
Well, it's an interesting question. I don't know to what extent this has been formally studied, but I think everybody has the general sense that, for instance, multidisciplinary collaborative team meetings where everybody comes together around all the available diagnostic data and sort of puts their heads together and brings different clinical perspectives to the same problem, end up being situations where, you know, more heads are better than one. And I think that that's fairly clear. And it's certainly clear that there's ample evidence in sort of non-clinical diagnostic settings and educational settings or whatever that when teams are working together and they are of roughly equal skill, that the team as a whole, on average, will always outperform any one individual member of the team. The problem is that there are times where expertise is differential, and you could have 4 team members talking together who didn't know anything about a very rare problem such as superior canal dehiscence syndrome, which is a funny cause of dizziness that patients complain of weird things like the world bouncing up and down when they turn the television up too loud. And in situations like that, having sort of that one unique person around somewhere who knows the answer may be better than having 1,000 people who've never heard of it. So on principle, I think it's going to vary a little bit, and for common and commonly encountered problems, it may be true that coming together is a better way. Whether the sort of remote access ways of getting together is necessarily as good as the in-person one, I'm not so sure. I think, you know, Martin alluded to this earlier, this idea that we've lost some of the communication, as did you know, sort of going down to radiology and learning from our colleagues and actually conversing. And I think that the struggle with doing some of this remotely is that it ultimately is not as effective as that direct personal communication. So I do think that there may be opportunities for online communities and discussions, and maybe even in certain situations, official kind of crowdsourcing, where you put a question to 1,000 knowledgeable people and you take the average answer, like the jelly beans in the jar, and that's probably your best bet in a diagnostic conundrum where you've got experts on the line.
Yeah, that's interesting comments. I'd like to ask Martin to follow up on that. Martin, I've seen this work really well like at a tumor board, where you bring all sorts of different expertise to bear in thinking about a given case. Do you think, I mean, do you wish you could do that on every case, or is that just for the special ones? What do you think?
I personally think it's better use of my time to attend only when there are special issues. When the patient has really no diagnostic discrepancies. I mean, everybody agrees what the diagnosis is. Then it's an issue of, well, what's the treatment? And the treatment can often be totally dictated by the protocol, and particularly if the patient isn't there, and they commonly aren't at these meetings, really what one should define is what are the treatment options and is there any evidence to favor one over the other, and then somebody or other has to put that to the patient. So I tend not to go to every meeting just because I'm interested in breast cancer. I only go to ones when there is a particular problem relating to a patient I'm familiar with, where I'm interested in other people's perspective.
Thanks. Does anybody else on the panel want to comment on crowdsourcing? I've seen online that there's some services that allow physicians to describe their patient a little bit and get feedback from people all over the world. Has anybody used those? I'm taking that as a no.
You know,
I have not used that service, any of those services. I do think in terms of the crowd or having multiple consultants, it's the who is, and as a it was alluded to earlier, who in that crowd is more important than the actual number in the crowd. And there's also in terms of quantity, or the more numerous does not necessarily mean the better quality. And so the who, again, is the key. And then there's probably actually a point of diminishing return where too many voices is actually counterproductive.
Yeah, you get into groupthink. And it sounds like both you and David endorse the idea that the quality of your collaborators is probably more important than the quantity.
To that point, Mark, I just want to point out, we're actually experimenting with that. We've just actually created a platform online for our best doctors. We haven't rolled it out yet. We're going to roll it out in about 2 weeks. We've been working on it for about 5 months, and our hope is we're going to test it. We're going to test it and invite physicians like the ones on the call. In fact, if you want to be part of just testing it, you could request to be a part of our beta test by the feedback form up there. But we're going to just test it and see if groups of specialists get some value from being able to use a digital form to collaborate online around a patient case with some of the necessary imaging tools that are required to look at a case. So it's sort of like a tumor board but on steroids. We're going to see if it works and if doctors find value in it.
That'll be a fun experiment. Thanks, Eric. Eric, I think this may be a good point to wrap it up. It's been a fun discussion, lots of interesting ideas back and forth. So let me turn it back to you.
Thanks, Mark. I appreciate it. I want to thank everyone in attendance for taking the time to join us today. We will be happy to send you a copy of what Best Doctors provides, these expert reports. We use physicians like you on our cases all the time, so if you want to get involved, you may request to do so by way of the form that's in front of you. We also could send you information around the conference that David was talking about earlier as well. So I'll leave that up there for a few minutes after the session. A very special thank you to our attendees in Australia who got up bright and early, and especially our panelists. Thanks so much for your time and your valuable insights. We really do appreciate it. So thank you all. Mark, great job. Thanks again for being part of our sessions. We really do appreciate it. And on behalf of Darren and the entire team behind the scenes, we thank you all. This will mark the end of the call. We'll see you next month on a Best Doctors webinar. Take care now.
Thanks, Eric.